an upper GI bleed. Whenever there is one of the most life-threatening conditions which is present, and it is an abdominal emergency. So it remains one of the commonest cause of hospitalization. Now, upper gastrointestinal bleeding is defined as bleeding derived from a source proximal to the ligament of Treitz. Now, this ligament of Treitz is present from the duodenal jejunal junction. It is a duodenal muscle fold which is present from the duodenal jejunal fold up to the connective tissue around the superior mesenteric artery. So above all that is considered as the upper gastrointestinal bleeding. Now it can be categorized as either varical or non-varical. Varical is a complication of end stage of liver disease, while non-varical is associated with peptic ulcer disease or other causes of upper gastrointestinal bleeding. Okay, coming to the next part is, now these are the important structures which are present in the upper gastrointestinal part. One is the esophagus, one is the duodenum and the stomach, the liver, some attachments with it. So all these structures which are near about causing the major causes for this upper gastrointestinal bleed which is present. Now what are the causes for this gastrointestinal bleed? They can be categorized into either the esophageal causes, the gastric causes, and the duodenal causes. Now, to start with the esophageal causes, the most commonest is simple plain esophagitis, then esophageal ulcers, esophageal varices, esophageal cancer, and Mallory-Weiss-Ted. So these are some of the commonest causes, esophageal causes of hematemesis. The next one are the gastric causes. Again, gastric ulcer is one of the most common. Then gastritis, gastric cancer, gastric varices, or diffuse lesions are known to occur. Now, what are the duodenal causes for this upper GI bleeding? In the duodenal causes, again you have the duodenal ulcer, vascular malformations, hematobilia or bleeding from the biliary tree, hemosuccus pancreaticus, that is bleeding from the pancreatic duct, and superior mesenteric artery syndrome is also known to be one of the causes of this upper GI bleeding. Now, as you are seeing here, the most common causes, what are the common causes according to percentage here? Most of the times are the NSAIDs or H. pylori. In that, the peptic ulcer accounts for almost 35 to 50% of the upper GI bleed. Then esophagitis, varices, Mallory-Weiss-Ted, then cancer of stomach, and autoduodenal fistulas. So these are some of the commonest causes of this upper GI bleed. Now, what are the signs and symptoms? Most important is hematemesis, that is the vomiting of blood. So whenever the patient usually present with hematemesis, then melena is one of them, hematochezia, syncope, dyspepsia, epigastric pain, heartburn, diffuse abdominal pain, dysphagia, and weight loss. Most of the times, the patient might start with epigastric pain or heartburn and abdominal pain, followed by a severe bout of hematemesis is present. Melena is present in few cases. In very rare cases, hematochezia is present. Hematochezia is usually more common with the lower GI bleed. Now, what is hematemesis? Hematemesis, it is vomiting of blood, could be digested blood in the stomach. It is usually coffee ground emesis that includes slower rate of bleeding or fresh unaltered blood. So gross blood and clots, they indicate rapid bleeding. So most of the time we are more fearful about the rapid blood loss, which is the fresh bleeding, and the coffee ground indicates that the blood is present for some more of time. Now melena again, what is melena? It is stool consisting of partially digested blood. It is black, tarry, semi-solid, shiny, and has a distinctive odor. And when it presents, it indicates that blood has been present in the GI tract for more than 14 hours. The more proximal the bleeding site, the more likely melena will occur. Now, what is hematochezia? Usually it represents a lower GI source of bleeding. But if the bleeding is present from proximal ends, then there will be fresh bleeding which is going to be present. Now, approach. How do you take a approach towards a patient of upper GI bleeding? First foremost, the history plays a major role. So, taking proper history of the patient, inquiring about the abdominal pain, hematemesis, hematochezia, melena, then features of blood loss. Whether most of the times the patient may present with shock, syncope, or anemia, or whether there are features of underlying causes are there like dyspepsia, jaundice, and weight loss. So history is one of the most important thing whenever you are dealing with upper GI bleeding. Also, drug history plays a major role. Most of the times, if elderly people are going to be there, the NSAIDs play a major role. Aspirin, corticosteroids, anticoagulants, particularly fluoxetine and sertraline. So these are the drugs which are known to cause gastric ulcers, and they lead to bleeding or hematemesis is going to be present. Now, history of epistaxis or hemostasis to rule out the GI source of bleeding is also important. A past medical history plays a major role, wherein previous episodes of upper gastrointestinal bleeding, diabetes mellitus, coronary artery disease, chronic liver or renal failures are known, or chronic obstructive pulmonary disease are known to be there. Now, what are the examinations you would like to do? The first and foremost is a general examination, which plays a major role. Now, in this, the pulse and blood pressure are more important. The pulse is usually there is a thready pulse, and in the blood pressure there will be orthostatic hypotension. Signs of shock will be there. There will be cold, clammy skin is going to be there. Then there is going to be profuse sweating, and hypotension is going to be there. So usually sometimes the patient will be brought in shock entirely, wherein there will be hypotension is going to be present. Now we have to see for skin changes also. This occurs usually with the chronic cases in the hematopoiesis where liver cirrhosis is going to be there. Now liver cirrhosis is one of the most other important causes for this upper GI bleed which is going to be there. In cirrhosis, you will have pulmonary erythema, spider nevi, and bleeding disorders are known to occur, but these are very rare. Purpura or ecchymosis can be there. Also, coagulative disorders are known to occur, hemarthrosis or muscle hematoma. Now, sometimes they will be added with signs of dehydration, wherein dry mucosa, sunken eyes, skin tugger will be reduced. So then another cause which is a tumor, they will be present with nodular liver, abdominal mass, lymphadenopathies are going to be there with the skin changes also. Now, what are the lab investigations? Most important, the lab investigations play a major role for this upper GI bleeding. First and foremost important is the complete blood count. So how this complete blood count is going to be helpful? According to the hemoglobin level, you will come to know how much loss of blood has been there, and you can plan accordingly for transfusions if needed. And then we have to know for the hemoglobin value. At the same time, you have to take blood for cross matching. Why? Because of heavy loss, you have to keep a blood ready so that when a particular level is acquired, you have to think of blood transfusion. That's why blood has to be cross-matched and kept ready. Then other important thing is you do the LFTs. Liver function tests play a major role to detect out the underlying liver disease. Also, the renal function tests are important to detect underlying liver diseases. So up till now we have said that CPC, blood cross-matching, liver function tests, the renal function tests are going to be important. Blood urea creatinine ratio increases with upper gastrointestinal bleeding. A ratio of greater than 36 in a patient without renal insufficiency is suggestive of upper gastrointestinal bleeding. The patient's prothrombin time, activated partial thromboplastin time, An international normalized ratio should be checked to document the presence of coagulopathy. They are also one of the important causes of this upper GI bleed. Now, prolongation of the prothrombin time based on INR of more than 1.5 may indicate moderate liver impairment, and a fibrinogen level of less than 100 milligram per DL also indicates advanced liver disease with extremely poor synthetic functions. Now, one of the most golden mark in our surgery is the endoscopy. It plays a major role in the diagnosis as well as the treatment of this upper gastrointestinal bleeding. It is like a blessing to have this endoscopy because you come to know the diagnosis immediately and the treatment can be carried out. Now, initial diagnostic examination for all patients is one of the essential to patients having upper gastrointestinal bleeding to do an endoscopy. Endoscopy should be performed immediately whenever needed with a patient of upper GI bleed. If the patient is having a massive bleed, you should actually, if needed, under endotracheal intubation, hemodynamic stabilization, and adequate monitoring, then you go ahead with the endoscopy. So with the endoscopy, we will come to know the exact cause of why the upper GI bleed is there. This is one of the diagnostic tool for upper GI bleed. As you see in the figure, we have instilled in the gastroscope, which goes in from the pharynx into the esophagus right up to the stomach. So you will come to know with the help of the lavage what type of from where the bleeding is there. You can see it is gone right up to the stomach, and with the V-turn, we are able to see the fundus of the stomach. Now, other investigations which are needed, one is the chest X-ray. Chest X-ray should be done to exclude aspiration pneumonia, effusion, and esophageal perforations. Also, abdominal X-rays are done to exclude perforated viscus and ileus. The next important is a CT scanning and ultrasonography. Now, why this is important? Whenever we are suspecting liver disease with cirrhosis or cholecystitis with hemorrhage, pancreatitis with pseudocyst and hemorrhage, aortoenteric fistulas, and other unusual causes of upper GI hemorrhage, that time this computed tomography scanning is going to be useful. Also, nuclear medicine scans, they are going to be useful in determining the area of active hemorrhage. Sometimes we will not be able to detect out the bleeding points on endoscopy or CT. That time nuclear medicine scans are going to be useful. The one more important investigation is an angiography. Now, angiography may be useful if the bleeding persists and the endoscopy fails to identify a bleeding site. Angiography along with transcatheter arterial embolization should be considered for all patients with a known source of arterial upper gastrointestinal bleeding that does not respond to endoscopic management with active bleeding and a negative endoscopy. Also, in aortoenteric fistula, angiography is going to be useful. Now, one more important thing is a nasogastric lavage. This is an important diagnostic tool. Now, even though it is a diagnostic tool, it can be helpful. It is one of the most easiest procedures, can be done anywhere, or wherein a Ryle's tube is passed through the nose into the pharynx and esophagus. Now, the procedure confirms recent bleeding. If coffee ground appearance, active bleeding, that will be red blood in the aspirate that does not clear, or lack of blood in the stomach, active bleeding, less likely but does not exclude an upper gastrointestinal lesion. Herein we are seeing how in through the nose tip the nasogastric tube is passed into the esophagus and then into the stomach. Now, what are the benefits of this lavage? better visualization during endoscopy. So whenever we are doing an endoscopy and instead of having fully a blood picture, it is better that we give a lavage so that we can have a better picture. Give crude estimation of the rapidity of bleeding. It prevents the development of photosystemic encephalopathy in cirrhosis, increases pH of the blood, and hence decreases clot dissolution due to gastric acid dilution, and tube placement can reduce the patient's need to vomit. So usually during this gastric lavage, we use saline and not to use very large quantity of water, otherwise it will lead into water intoxication. Now, there is a score which decides the risk facility of this upper GI bleeding, which is called the Rockall score. You can see in the table, it is categorized into score 0, 1, 2, and 3. First, we see the age of the patient, then the comorbidity, shock, source of bleeding, and then stigma of recent bleeding if it is there. Score 0, as we see, it is less than 60. Score 1 is 60 to 79. Score 2 is greater than 80 years of age. Comorbidity, none of the comorbidities in score 0 and 1. In score 2, you have congestive heart failure, ischemic heart disease. And in score 3, you will have renal failure, liver disease, metastatic cancer diseases are present. In again shock, they will be in score 1. No shock will be present in score 1. Pulse will be above 100. And in score 2, hypotension is going to be present. Now the source of bleeding, what is the cause? In score 0, you have Mallory Weiss, and in score 1 covers most of the causes like esophagitis, gastritis, peptic ulcer disease, and varices. And in score 2, you have the malignancies. Now, how this is graded? After grading of the score, now Rockall score, if it is greater than 8, high risk of death is there, and Rockall score, if it is less than 3, excellent prognosis is present. So if you want to know the prognosis of this upper GI bleed, for that purpose, this Rockall score is going to be useful. Now, management wise, usually there are various priorities. First, it is usually patient is taken into an intensive care unit. First, you have to stabilize the patient, protect his airway, and restore circulation. So first, stabilization of the patient, maintaining the proper airway, otherwise there will be aspirations more, and restoring circulation is going to be important. Now, the second important thing is then you have to identify the source of bleeding. So once you identify the source of bleeding, you know what treatment has to be chosen by you, and then you go ahead with the definite treatment of the choice which you can follow. Now, resuscitation and initial management, as I told you, first we have to protect the airway, position the patient on one side, see that you access proper airway is maintained properly. Then intravenous access is taken secondly. Once you take the intravenous access, you take blood for the complete blood count, prothrombin time called cross-match, and restore the blood circulation. If make the patient hemodynamically stable till the blood is available, because by the time you send the blood for cross-match, you have to wait, give some time, and then in the meantime, you have to keep the patient hemodynamically stable. So once you restore this first step of maintaining a proper airway and maintaining the IV circulation, it is going to be important. Now then, blood transfusion, whenever massive blood loss is going to be there, that time you think of blood transfusion. Now, hematocrit, if it is less than 25%, it is usually active bleeding is there, and usually symptoms are due to low hematocrit and hemoglobin. Platelet transfusions are to be given, fresh frozen plasma is to be given. Now, apart from this, once you stabilize the patient, then monitor, you have to monitor for urine output, watch signs for fluid overload. See, you should not have a total fluid overload. So you have to monitor that, otherwise patient will end up into pulmonary edema and peripheral edema. So JVP, the jugular venous pressure has to be maintained so that you can come to know that you are giving the fluids properly. You have to commence IV, proton pump drugs are to be given. usually preferred omeprazole, and then keep the patient nil by mouth for endoscopy. So once you stabilize the patient, keep everything ready, then we plan for an endoscopy. Endoscopy could just be a diagnostic one, or you could plan a therapeutic at the same level. Now, sometimes now treatment of varicose bleeding, the bleeding is either varicose or non-varicose. Varicose usually it is associated with liver diseases, or non-varicose bleeding is there where gastric ulcer, peptic ulcers, duodenal ulcers are going to be there. Now, in this, you should, whenever you are doing treatment of varicose bleeding, terlipressin treatment should be stopped after definitive hemostasis has been achieved, or after 5 days, unless there is indication for its use. Usually, we prefer giving a prophylactic antibiotic therapy, and balloon tamponade is considered as one of the temporary salvage treatment for uncontrolled varicose bleed hemorrhage. So whenever uncontrolled varicose hemorrhage is going to be there, the immediate thing we could do is a balloon tamponade could be put in. The next, as you see here in the figure, we are seeing how a balloon tamponade is put into the stomach to compress the bleeding. Now, bleeding, either it could be the esophageal, from the esophageal varices, the gastric varices. When it is from the esophageal varices, we prefer band ligation. Band ligation is, I'll show you the figure I had, wherein a band is placed at the base of the varices. Now, stent insertion is effective for selective patients, or transjugular intrahepatic portosystemic shunts are considered if the bleeding from esophageal is not controlled by band ligation. Most preferred for the gastric varices is endoscopic injection of N-butyl 2-cyanoacrylate can be used. So that one, they are also commonly used wherein endoscopic injections are given. Wherein we use sodium tetradectyl also is used. 3% STD. Now this is a figure of a esophageal varices. You can see one esophageal varice which is present prominently. Also, this is a figure which shows a rubber band, how it is put. And in the C figure, you are able to see how the band is placed at the base of the varice. Now here in the next figure, you are seeing how sclerotherapy is given, wherein the needle is inserted and the sclerosant is injected. This is most commonly preferred method wherein sclerosant injections are given. They are giving best results and one of the most preferred results by the gastroscopists. Now, what is the treatment of non-varicose bleeding? While non-varicose bleeding, as I told you, they are acutely present. It could be peptic ulcer, gastric ulcer, esophageal ulcer, esophagitis. Now, endoscopy is now the method of choice, most common choice for controlling active peptic ulcer related upper gastrointestinal bleeding. Now, endoscopic therapy should be delivered to actively bleeding lesions, non-bleeding visible vessels when technically possible to the ulcers with an adherent blood clot should not be tethered, or black or red spots or clean ulcer base with oozing do not need endoscopic intervention. So we should not go to disturb them, otherwise they will start re-bleeding because they are settling. We should not intervene with them. Now treatment again for the endoscopic treatment of non-varicose upper GI bleeding. The mechanical method is with the clips. Usually clips are put at the base of the vessels which are present. Thermocoagulation with adrenaline, fibrin or thrombin with adrenaline. These are some of the preferred which are done treatments of non-varicose bleeding. In this figure, you are seeing how a clip is based the vessel which is seen so that it will control the bleeding actively and acutely. Now, if with all these methods, if the bleeding doesn't stop, then we give a thought of surgery. If persistent hypotension is going to be there, failure of medical treatment or endoscopic hemostasis is going to be there, coexisting conditions are there like perforation, obstruction, malignancy, then transfusion requirements are being more and more, 4 units in 24 hours, and recurrent hospitalization, then in such conditions, we prefer surgery. These days, with the advent of endoscopic treatment, less surgeries are being done for upper GI bleeding. Usually, they are well controlled by the endoscopic treatment. Now, what are the types of operations usually? Duodenal ulcers are treated by underrunning with or without pyloroplasty. Gastric ulcers are usually treated by underrunning. Take a biopsy also to exclude carcinoma, and local excision or partial gastrectomy will be required if there is excessive bleeding, and with all such procedures our bleeding is not getting under control, then we go ahead with partial gastrectomy. Now, what are the complications? Now, complications usually they start right up from endoscopy. They could be aspiration pneumonia, they could be a perforation, they could be complications from coagulation or laser treatment. Even surgical ileus can be present or sepsis can be present. So these are some of the complications of this upper GI bleeding. Now, while always prevention is better, nowadays with the advent of so many proton pump drugs, we are rarely able to see gastrointestinal bleeding. Usually if the patient takes the diet properly, if he takes his less stress induced and with proper medications, then we can treat out upper GI bleed properly and we can prevent out. So with these newer drugs, we are seeing less upper GI bleeds are seen. Only in more varical bleedings are more seen. The gastritis or the esophagitis are well controlled with this all these drugs which are present. As such, to bulk it in short, upper gastrointestinal bleeding is an acute emergency. If treated in time, endoscopy is the golden star for this upper GI bleed. And if treated with proper proton pump drugs, or if treated with proper banding and given in time, there is less morbidity and mortality with the upper GI bleeding. Thank you.